Okay,
And
it does. Yeah.
Okay, Dr. Ahmed.
yeah,
Yeah. So your first case. Can you see my screen, right?
yeah, I can see your screen.
Okay. Yep. Fever.
Actually, Dr. Kamal, it's not enlarged. It's just stuck again.
Sorry.
I can see only the icons, not the image.
Just wait a minute. Let me share it again. Can you see now?
Yeah. No, no, yeah, now I can see it.
Yes.
Okay.
Yeah.
Yeah. Yes. Fever.
I have been provided with a lateral view of cervical spine, including soft tissue of the neck, in a patient who has come with fever. I can see that there is significant increased prevertebral soft tissue swelling seen opposite the cervical spine vertebrae, which is displacing the trachea anteriorly. No obvious gas pockets are seen, and no obvious calcification noted. There is some lordosis of the cervical spine, which could be due to the mass effect by the soft tissue entity, which is seen here. So in a patient with fever, I would think in terms of a prevertebral abscess or a prevertebral cellulitis. In my routine practice, I would correlate with any previous radiograph or any uh, AP view or any other imaging modality,
No other
and
imaging
refer.
available.
Okay, I would refer the patient for ultrasound and CT neck, including the chest, for further evaluation. And this has to be done with the contrast
So
study.
what you want to evaluate in the neck and chest in the CT scan, what additional benefit that will provide you?
That will help in confirming the diagnosis of a abscess, or if it is in neoplastic etiology. However, in a patient with fever, I would be thinking in terms of a infection, and would also
So what
know the
neoplastic
mediastinum.
etiology you are thinking in this case?
Probably any lymph node which could be there, like a lymphoma or something, but very unlikely to be such a huge thing. But still, in a CT, or also correlate with the mediastinal extension of the entity.
Mm-hmm.
So
Okay. Can you see the next case?
yeah,
Okay. So can you ask the control from me?
sure. I did.
Okay. Yeah.
Okay.
Can you?
Yeah, sure.
Can I just, Dr. Kamal, we can see the name of the patient.
Okay. Let me.
Okay. I have been provided with axial T2 images, brain study MRI. So I would like to scroll the images from the top. Okay, this is bad.
You can just use your
Yeah,
mouse or yeah.
I'm using.
Okay.
So coming from the bottom, in a caudocranial direction.
Mm-hmm.
In a 5-year-old patient, I'm looking through the axial sections. I did not find any gross abnormality. However, yeah, there is posterior T2 uh, T2 hyperintensity in the peritrigonal region, and also in the frontal region, including the centrum semioval. This shows T2 hypointensities which are perpendicular to the uh, sagittal mid, which are perpendicular i- and along perpendicular to the axis of the ventricle,
Mm-hmm.
and okay, and grossly I could not find any gross gyral abnormality in this case. So I would
Mm-hmm.
correlate with these findings on T2 flare and T1 and contrast study
Okay.
if available.
Why you want contrast in this case? This is the flare.
Okay. In contrast, to know whether because
What are you thinking first?
yeah, this in a 5-year-old, I could think in terms of a dysmyelinating disorder, uh,
Such as?
such as adrenoleukodystrophy, or not getting that name. I'm just forgetting it.
So how the
Adrenoleukodystrophy.
contrast study will help you in the
It helps in
desmyelination?
knowing the acute and chronicity of the disease. The acute thing enhances, and it helps in knowing the staging,
How
whether it is still
how
inflammatory.
much think you it's acute or subacute or chronic in 5-year-old case?
This looks like a chronic to me in this case, but if there is a contrast enhancement at the leading edge, so it indicates that the disease is progressing, the dysmyelitis is
Can you
progressing.
please point with the mouse that what is the leading edge?
In this is not a contrast, so means this yeah, you can see my mouse.
Yeah.
Yeah, this one, if it is like enhancing, then it tells you that it's a leading thing, the inflammation is spreading.
Inflammation. So you think it's inflammatory?
Sorry, I would like to retract that statement. Means the demyelinating disorder is like spreading.
Okay. What else? So what you think is the prognosis in this case?
In this there is I would like to see in T1, because to know how much amount of white matter volume loss is there, because
This is T1.
yeah, on the T1 there is a good amount of white matter volume loss, and looking at the T2 flare, which is very much hyperintense, this suggests that uh, it's more of a moderate to severe
So
degree of
can you tell me
dysmyelin
the
disorder.
prognosis of the disease? You told me that you said, I think so, adrenoleukodystrophy something.
Yeah, adrenoleukodystrophy, and the other one I'm forgetting. I'm not able to
So
recollect.
okay, fine, that's fine. But
Metachromatic leukodystrophy.
what's the prognosis of adreno?
Adreno. Uh, I do not recollect. It is usually autosomal recessive, I believe, and the prognosis is not very good. Uh, I'm sorry, I'm not able to recollect.
Yeah, that's fine. Okay, you have the mouse control, or you have to ask for it again, I think.
No, I can just click it and scroll.
Yeah. Football player.
Okay. I've been provided with axial images, T2 sections of foot of a football player. So I would like to see first the posterior tibialo fibular ligament to look for, sorry, talofibular ligament. And
Okay,
on a
forget the
T2,
ligaments.
okay.
Anything gross?
Yes.
Scroll the
In
images
the
completely
base,
first, please. Go
sorry,
beyond.
sorry.
Yeah, that's okay.
So I did see that there was at the base of the metatarsal, this, oh no, that is fine.
So what sequence in foot you are usually comfortable with? You start your reporting with
PD fat sats to look the fluid sensitive signal.
axial or what? Okay.
Anything is fine, like coronal
Yeah.
or axial.
Yeah. Okay. Just wait
Yeah,
a minute. Just
sure.
1 minute, please. Yeah. Sorry for this. Yeah.
Okay. Okay. I have been provided with I cannot see the name. This looks like a fluid sensitive sequence in the fat saturated
Mm-hmm.
axial study. I can see that there is significant amount of uh, uh, T. This one is a T1 fat sat image. So there is significant amount of T1 fat sat hyperintensity, which is seen in the subcutaneous soft tissues.
Mm-hmm.
And also it is along the uh, tibialis posterior tendon. There
Mm-hmm.
is tenosynovitis.
That's fine. Anything gross, I said, like football player came with a sudden snap and swelling over the ankle region, posterior aspect of the foot. Anything else you would like to
Yeah, I would
see?
like to see the Achilles tendon
So can
to
you
look
like to
for.
comment for it?
Yeah, there is no. Okay, I'm scrolling from above. Okay, I'm not able to see the Achilles tendon distinctly, which presents as a T1, T2 hypointensity. So this is not seen very
Just wait a
distinctly.
minute. Wait a minute. Yeah, huh? You speaking. You speak. Keep speaking. Yeah.
Yeah, yeah. I can see that there is a discontinuity of the Achilles tendon at the distal 1/3, just proximal to the attachment to the calcaneal tuberosity. This suggests a possibility, or not possibility, this suggests Achilles tendon tear in a football player, which could be secondary to the twisting injury or trauma. I would
Okay.
confirm my
Which could
findings,
be?
and which could also be in a
Yeah.
if the patient has any diabetes,
Okay. Okay.
uh,
Fine. That's fine. Yeah.
and refer the
So
patient to orthopedician for further evaluation.
fine. Next case. Yeah.
I've been provided with T2 axial images. Mm, Going through all the images. Okay, I could see that there was a CP angle tumor, which is on the right side, and which is causing significant mass effect over the mid pons and right middle cerebellar peduncle. I'm like trying to look at the extension into the internal auditory canal, and I can see that there is an extension of the lesion into the internal auditory canal on the right side, which is causing widening of the canal.
So what do you think it could be?
This could represent a vestibular schwannoma. So I would like to do a contrast study for this patient, and to look for any erosion. I would like to do a CT scan and refer the patient to a and screen for any other schwannomas
What you want to do for CT scan for what?
for
Sorry.
erosion of the internal auditory canal.
Okay. Okay. Fine. Yeah. So this is the next case for you. Hepatitis C positive.
Okay.
Go to the
I have
abdomen. Don't scroll that much. Like, let
okay.
me, yeah, go straight down. Yeah, start from here.
I've been provided with contrast enhanced venous images of a patient who is hepatitis C positive. In this section, I can see that there is moderate to gross left pleural effusion. Scrolling through the entire sequences once. Okay. I would like to look at specifically at the liver first. I could see that there was cirrhotic liver, and yeah, few patchy non-enhancing areas. So this I would correlate on the arterial phase. This looks like a venous phase to me, or I would like to
This
correlate
looks like a venous phase. How many venous phase you have seen actually? Like which, how can you
portal
identify the
venous phase.
phase?
Means if the density of the like there is no significant contrast in the portal, then there will be a arterial phase, and the arteries are enhanced much more. But in this case, I could not see a blush of artery.
Okay, fine. So
So this looks like a portal venous phase to me. So so in this I could see it is so just to confirm whether there is a washout, I would correlate in the arterial phase, because in a patient with hepatitis C, possibility of liver carcinoma has to be ruled out in a cirrhotic patient. And
Mhm.
I can see that there are a lot of collaterals in the porta hepatis region and also in the splenic region, and the spleen is also appearing enlarged.
So what's the role of interventional radiologist in this case?
Interventional radiologist usually, if there is for TACE, for ablation of the tumor, and if there is any rupture of the tumor and bleeding from the liver malignancy, means hepatocellular carcinoma, for embolization of the uh, bleeding vessels,
Mhm.
and also for the TACE.
So what about this? What is good for this candidate? So first confirm your diagnosis and then answer my
Yeah,
question.
this looks like a hepatocellular carcinoma in a patient who has chronic liver disease with the portal cirrhosis and possibly portal hypertension and a significant amount of ascites and pleural effusion, and with porto venous collaterals. So this suggests a hepatocellular carcinoma.
Mhm.
I would confirm, if I would aspirate the fluid and send for evaluation to, uh, and Howard CT is more of reliable, and uh,
So what are you doing, sending fluid for?
for malignant cells, if I could find,
Okay,
and
so you are doubt of malignancy yet, yeah?
no, I'm not in doubt, because CT has a good sensitivity in detecting hepatocellular carcinomas in the triple phase CT. So
Uh-huh.
so this is a portal hepatocellular carcinoma, just for additional histopathological support.
So fluid will give you the histopathological diagnosis, right?
Not the not the histopathological, only the
Yeah,
aspirations of
that's
fluid.
okay. Just
Yeah,
I am confronting your statements.
yeah,
This happens in the exam, and
yeah,
this we speaks, which is usually wrong. We are not doing it in the usual practice, actually, right?
yeah.
So this is like whatever you speak is like written in their book, and they are noting that point. That is giving you a plus or a minus. So
Mhm.
whatever you are saying, even a single word, that matters at the time of examination, especially
Yeah,
during the Viva. On the written, maybe like in the long cases, maybe it's like hidden up, but on the Viva, you can't be spared from any word you are speaking. So we
yeah.
have any more time for, or should I move?
Yes, Dr. Kamal, actually, for every
Yeah,
candidate, you have 30 minutes.
yeah, that's great then. Okay.
So, but including the feedback. So you can go on with the Viva maybe till 22, 25 minutes. It's up to you.
Yeah, sure. Sorry. Yeah, can you see?
Yeah.
Okay.
Okay. I have been provided with frontal radiograph of both the knee joints in a skeletally immature individual. The gross abnormality I could see is that there are multiple lesions which are arising from the metatarsal region and extending away from the joint plane. Uh, and This represents osteochondromas. The other pathology I could see is that there is significant of amount of chondrite calcification, which is projected over the right upper uh, uh, tibia fibular region. So I would like to correlate this on a lateral view if available to
Sorry, I
look.
don't have that.
Okay, so in my routine practice, I will correlate the lateral radiograph, and in this, I would be worried about any possibility of malignant transformation. I would like to correlate the clinical features, whether the patient has any recent increase in size or any pain at this site
Any
in the right
specific
knee.
name for this you can tell me?
malignant transformation of osteochondroma.
So for this multiple
Yeah,
osteochondromas.
diaphyseal Achilles with
And what's
possibility
the
of
chances of malignancy in this?
the chances of malignancy are relatively higher in a patient with multiple osteochondromas
How
with
much?
having so much amount of exactly I do not remember, possibly it was like 20 to 30%.
Okay. So in this case, you see any
I would
worrisome feature in any, or?
yeah, on the right tibial on the right lesion which shows a significant of calcification, I would be worried
So
whether
patient is
it's
having a active pain on the right side then?
yeah, when the patient has active pain, I would be more worried and do a MRI scan to look for the cartilage cap thickness
Mhm.
and in view and measure the cartilage cap thickness. If it is more than 2 centimeters, I would be
MRI can't be done for the next 1 week, then any other possibility you can
I could do an
look for?
ultrasound in this case to look for the cartilage cap thickness.
Okay.
So if there is any
So,
discontinuity of the calcifications,
okay.
so I'd be worried whether a malignant transformation is happening on the right side,
Okay.
and refer the patient to a multi-dissimilate tumor for further management.
Okay. So this is the last case for you. Yeah. You can scroll it for me. Patient came with weakness.
I have been provided with a T2 axial brain images of a patient who has come with weakness. Scrolling through the all images. Okay. I did see a pathology in the midline. So I can see that there is T2 heterogeneous intensity, which is in the parafalcine region anteriorly. In a patient with weakness, I would be worried about possibility of any infarct. So I would like to look at the diffusion weighted images if available. So,
This is diffusion.
okay, and the diffusion, I can see that there is patchy heterogeneous hyperintensity. I would correlate with the ADC. Okay, on the ADC, I can see that there is diffusion restriction, but this is not conforming to the vascular territory. This looks bilateral in the parafalcine region, and which shows few areas of heterogeneity on the T2 flare. Sorry, on the T2 sequence which was given. So I think my differential will be that of any neoplastic etiology in a patient who has come with weakness. So I would correlate in the T2 flare and do a contrast study. Yeah.
Sorry, I don't have the, okay, contrast one, I don't have it. So anything else? What neoplasm in this case you are considering? What sort of neoplasm? Can you name any?
Glioblastoma. The other possibility could be of if it is communicating with the ethmoid or nasal cavity, or be concerned about any
Okay,
olfactory
ethmoid and
neuroblastoma.
nasal cavity. So here you can see, yeah. Is it?
It's not extending to the ethmoid or the nasal cavity. I could not see any.
Okay.
Yeah, I could not see any extension. But yes, it is close to the olfactory nerve. So
So is
I would
there
an
any destruction of the cribriform plate or something?
no, I could not see any vivid destruction of the cribriform plate, which appears intact in this case.
So
This suggests a possibility of this is not looking like a
so what
solid
you
tube.
think about the right eye in this
Sorry,
case?
yeah, I did see it, but I apologize. I did not forget to mention it. There is a good amount of hemorrhage within the means T1 hypointensity and T2 hypointensity. T1 I did not see it. The
So what
T2
you
I could see.
think? Have you? So what is this?
Yeah, I would be
This is
concerned about possibly of a metastasis, possibly a melanoma. I would like to
Okay.
look on the T1 sequence to look for the uh,
Okay, okay, fine. Thank you. Thank you. So coming to the feedback then, okay.
yeah.
So how you think you have performed?
No idea. Some
That's
areas.
completely okay. Yeah. Are you appearing in this exam, right?
Yeah.
Okay, fine. So you know most of the things, but actually some of the statements, to be very frank, are quite distracting, which
Yeah.
takes you totally away from the main diagnosis you are about to say. And what I don't like is it looks like it could be. These statements are like very confusing. Like you are totally doubtful about your own statements you are making, right? So
Yeah.
examiner thinks that you are like a shaky radiologist. You are not safe because you are not definite about anything, right? Which
Yeah.
I think so you have an ample time and you can improve it. Okay.
Yes.
So this is the main thing among all your description, rather diagnosis right, wrong, or whatever that is. But the main thing which you have to improve is like, don't be so much distractive. Like one time you are saying like that, like in this case, you were saying that it is a retropharyngeal abscess, and then you said something carcinoma, like, so it's totally two distractive things.
Means we cannot give differential because
You
considering
can
any
give
lymph node.
differential. Like, let
That
me tell
was
you
fine. Okay.
the cases. There are some things which are short. Like when
Okay.
it is a venous phase, it's a venous phase. It can't
Yeah.
be, could be the venous phase,
Yeah.
right?
Yeah.
It is a venous phase, so it's a venous phase. And when the things like are doubtful, when the things are, this is a case of differential diagnosis, you have to tell the differential diagnosis. In this case, like it's a quite huge widening of the peripharyngeal space and so prevertebral soft tissues you can see, but no definite vertebral erosions. There is elevation of the trachea anteriorly. It pushed much. I tell you the history of fever. So first thing one should come in mind is the retropharyngeal abscess, right?
Yeah. Yeah.
So there is no tumor, nothing else. Patient doesn't develop such much huge swelling in a day or two, or like in a just a short period of time. So it is an abscess. There is no doubt in that. Okay.
Okay. Okay.
So I think so to say tumor in this case is not justifiable. That's why
Okay.
I like poke you
Only
and
one
then decide.
diagnosis.
Yeah,
Yeah.
only in this case it's a one diagnosis. To check for the ultrasound is fine. Like you give the justified reason for the CT scan. Okay, so you want to see its extension. That's okay. I don't deny that, but just to refer to the main pediatric and for the emergency drainage is like the best answer should be told on. And if they are concerned about the more extension and to look for the extensions, then they will advise the city themselves, right?
Okay. Okay.
So I think so you should say that it is a retropharyngeal abscess, and I will refer the patient immediately to the pediatric department or to the other interventional department for the drainage of this, right?
Okay.
That
Fine.
should be your report. So next case, this one, it's fine. Like these are multiple exostosis, diaphyseal eclasis. In some cases, you should know, like I was in a mind that they don't ask so much theory, but they do ask. They do ask. So such bookish cases, which are usually come in this is nothing much to tell. Everybody knows that is every radiologist should know that is exostosis. I'm not showing you any pathological fracture over here. Yeah, this appears to be doubtful, and so in this case, I'm more interested about your theoretical knowledge and so how you deal with the case. The best thing to answer in this case, in my point of view, is to look for the previous imaging, if any, which you haven't mentioned. In FRCR, remember this thing, always ask for the previous imaging.
Okay.
In this case, the best thing is any change, you can comment in the comparison among the different lesions, because these patients are on surveillance usually. So you can easily
get the images.
yeah. Okay, so this one you pick it up late. Okay, so it's fine. Yeah, it's your scheme, whatever you start with. But I am saying you again and again that something grows, something grows, something grows. And football player, then I don't think so that you will be shown such small ligament injury in the exam case. When this is an MSK case, there is some big bookish picture of that. Because even I don't know, it's the MSK radiologist duty to look for the ligaments, but for the ACL ruptures, general radiologist should know. Okay.
Okay.
So because they can treat it emergency and whatever they have to do with the patient, orthopedic will do it, right?
Sure.
So this case you did fine. It was the CP angle lesion. The only thing I must say that I think so this is well away from the internal acoustic meatus. It's
Some
quite superior and
this one superiorly right side it was there. I don't know.
sorry,
Okay. Okay.
you can see
There
that.
was yeah. It's
Yeah,
truncated.
you identify it. You identify the CP angle tumor. Sorry, hello.
Yeah. I can hear you.
Yeah. Okay. So I asked you said that you will see some extension into the internal acoustic meatus. You used that word, I think so.
Yeah.
But this is the meningioma because I think so. But I am trying to say that this is well away from the
It's well
acoustic
away.
meatus,
Yeah.
right? It has no link
But
with that.
superiorly I could see on the T2, but it was I think we should have to confirm on a T2 flare. That is better.
Okay. The best thing in the Viva to perform regarding such tumor cases, always in your description mention extraaxial or intraaxial, which you haven't. You just
Yes, I
said that
did.
it's a CP
CP
angle
angle.
tumor.
Yeah.
So such like this, it's also not fine. You should tell that it's either intraaxial or extraaxial or something. Okay. Okay. So coming to this one, it's fine. It's dysmyelination. Okay. It's demyelinating, dysmyelination, whatever you want to say. It's a leukodystrophy. It's a white matter disorder. The name coming in your mind, not coming in your mind, it's fine. It is metachromatic versus
I
adreno.
detail at the end, but
Yeah.
yeah.
Okay. So metachromatic is very well butterfly shaped and bilaterally symmetrical. So it is metachromatic, having a well tigroid appearance. I think so. Like these
Stripes.
this is a bookish case, which no differential. If it's posterior, then I would say that is adrenoleukodystrophy, right?
Yes.
What I am forcing over the prognosis question is it's important in this case because metachromatic has a better prognosis as compared to the adrenal. Okay. And I don't think so there is any benefit of the contrast in these cases. No leading edge enhancement or something like it's in the pediatric cases. You are not dealing with the multiple sclerosis or something. You are not dealing with the adult patient. You are dealing with the child. So not much needed in that one. Okay.
In the prognosis part, in the diaphyseal ecclesia malignant transformation, what
Yeah,
was
there
the
is a
rate?
specific percentage. I think so. It's a 40%. I don't know because the book
Okay.
people should know better. Okay. So I
No
don't know
problem.
it exactly, but
Sure.
to be very frank, it's a very favorite question of the FRCR theory exam, FRCR Viva's exam, everywhere. It's a very favorite question. You should not have. Okay.
Sure.
So I think it's 40% something, but somebody from the house can tell the exact answer. Okay. So I think
One another case was there. Parafalcine.
Okay. And one other case was this.
Yeah, this one.
So this could be the venous phase is like the most
I shouldn't be
pinching thing
telling
for
it
me actually.
because I was worried there was any no, I was worried there was any portocystic collaterals which could drain the arterial phase.
Okay,
So
but there was
that
a
is the reason
lot of things to tell in this case, which you were not saying. Cirrhotic liver morphologies, splenomegaly, extensive collaterals, ascites, recanalization of the umbilical vein with caput medusae, heterogeneous. This is not a lesion. This is a big lesion with exophytic components and a lot of vascularity in it, right? And so you will
I did summarize at the end because I was like, what HCC. So in this case, because in our routine practice, we send each and every fluid for analysis. So that's the reason I said, but I don't know what is the practice in the UK. Do they do it or do they don't do it? FNSC?
Well, to be very frank, it's not a very much long time I have spent yet in UK, just because I passed the FRCR, to be very frank, in March, and I joined UK in November.
Okay.
So it's fine. You can send the fluid to the cytology. There is no harm in that. But actually, in this case, it's not meant for the basic diagnosis, right?
Yeah, exactly.
You can send it for the superimposed infective etiology, for other things, and exudative and transudative like details, which the medical treatment depends on how to manage the drugs of the patient. But for this case, for the radiological point of view, these are the main points.
Yeah.
Okay.
And the interventional part, taste and anything else we have to say?
Taste was fine, but what I was like asking the taste, but that's fine. Yeah. Okay, so this one I don't think so you perform good. It is a very where is the ACA territory? In fact, if it's not arterial territory, then where is the ACA territory? Can you tell me?
AC means it is crossing the midline. That is the reason I was worried.
Edema can cross the midline, I think so.
Ah,
ACA
okay.
territory
That is the
infarcts
only
do
reason I was
appears
like,
this.
why it is crossing midline.
ACA
Okay.
territory infarcts do appear like this, okay, and due
And
to
the restriction was
spasms,
patchy. So
yeah,
that's
that's I'm going to explain that due
okay.
to spasm, sometimes when there's an infarct of the one side, it compresses the other artery because
Okay.
ACA are too close to each other, right?
Okay.
And sometimes there is it's not that hemorrhagic infarct you see in the DST something, or it's not at all a tumor. To say it a tumor is like quite pinching for me, to be very frank. Okay, it was totally not a good attempt. Okay, so more heterogeneity in this is due to because there is a hemorrhage.
Okay.
Okay, and the other thing, if you go beyond, is actually basically the aneurysm rupture of the ACA territory. So an ACA territory aneurysmal rupture with hemorrhage and infarcts in that territory is the basic conclusion of this case, which
I think on the T1 could have, if I would have looked at the T1, I would have told hemorrhage. Then I think
you have to ask for that. Nobody will show
like that's
you.
what
Nobody
obviously I
will
should
show
have asked.
you should have asked for the things you
T1,
want to
yes,
see, right?
yes.
But you said that I think so. It's not an infarct. You clearly said that it's not an arterial territory, which is like very clearly said that
because
you are
of the
not
crossing of the
thinking on the
midline,
lines of the
I
infarct.
wasn't like very sure. Yeah. This is a good point. Like because of the edema, it can be appearing on the right side. Yeah.
Okay.
Sure. Thank you. Thank you for the feedback.
Yeah.
Thank you for the wonderful
it's
cases.
totally like what I feel, what I am showing. I know my cases very well, so
Yeah.
That's okay.
No. That is good cases.
And the only thing to improve, I have already mentioned in the starting point that what actually you need to like, don't be confusing.
Yeah, I think I need to be more specific because considering this is an exam scenario. In a
there are
general
the things
radiology discussion, sorry.
Yeah.
In a radiology discussion, in a what do you say, telling with the consultants, we generally speak like that. But in an exam scenario, they are giving that for a particular thing. So I think we have to be more specific in an exam scenario. Like for example, that retropharyngeal case. So have to be more specific instead of generalizing.
Yeah.
Thank you for the video.
Yeah. Thank you.
Thank you, Dr. Kamal. Your next candidate would be Dr. Awad. Dr. Awad, you can go ahead.
Hello.
Yeah, hello. Can you listen to me?
Yes.
Yeah, how are you?
Fine.
Okay, so let's start with your first case. Sorry. Can you see?
Yes, but a little small.
Now it's a bit larger.
Yes, it is
okay. Yeah.
So I'm presented with a frontal radiograph of the abdomen of a skeletal hematoma patient.
Past history of ovarian surgery.
Okay, with a history of previous ovarian surgery, I can see at my first look there are multiple radiodense surgical clips in the left side of the hemipelvis, or could be this due to previous surgery or radiation. This is what strike my eye. Then I can see there's a dense opaque sheet-like of calcification seen projected over the abdomen peripherally. Also, there are multiple calcifications seen in the right hypochondrium and the left hypochondrium, and there is no free air. The bowel gas pattern is non-specific. There is no bony outline. I can't see any lytic or sclerotic region. I can see there are multiple bony sclerosis over the proximal femori. I wonder whether these are projectional or true there.
So what do you think these calcifications are?
Given that this is an adult female with history of ovarian surgery, I'm thinking of possibility of neoplastic process with the history of operation and radiation with peritoneal deposit and calcification. Also could be there is a hepatic deposit. So I will convey this finding to the referring physician and reviewing the medical record of the patient for any, what's that ovarian surgery, if it is neoplastic, and correlate this with previous image, and I will.
So anything specific for the mesenteric, if I tell you that these are in the mesentery and yes, you are on the right track, then anything specific name you can tell for this thing?
Yes, peritoneal carcinomatosis and pseudomyxoma peritoneal spread. I'm thinking of this.
Okay. Young child present with fits.
Okay.
You can ask the control, please.
Okay. Just remote control.
Yeah.
Presented a young child who presented, if I remember, with fit. So I will take a general look by this multi-sequential, multi-planar MRI. So from down up, I can see. This is an axial T2 weighted image where I can see large cystic lesion seen centered in the left cerebral hemisphere in the frontal horn and occipital horn of lateral ventricle with marked dilatation. I want to characterize this by looking at other different sequence.
What sequence you want?
I can start by T1.
Okay.
Okay, in T1 weighted image, I can see confirm the region of low signal, so with ISO intense signal to CSF, and there is a large ISO intense signal, ISO intense mass lesion seen in the occipital horn of the lateral ventricle.
So what you're thinking of?
There is also, I'm thinking of possibility of neoplastic process, which is centered in the choroid plexus. This, with this young child and hydrocephalic change, I would also like to.
So why, if you think of the tumor over here, then why is the problem over here as well? Can you justify this one?
Yes, because of the hydrocephalus, but I think there is also ependymal hyperdensity of the ventricular system and the signal void or abnormal signal, whether there is brief recent intervention or shunting. So I would correlate this with the contrast study. Yes, I can see now there is intense ependymal lining in hyper enhancement. This going with the ventriculitis. And the mass that in the occipital horn, I can't see any enhancement of it. So actually this enhancement on both sides, and there is no enhancement in the choroid plexus or which is seen not adherent to the wall. So I'm thinking of possibility of this as a more with inflammatory process such as ventriculitis.
Yeah, that's fine. Then what is the heterogeneity seen in this occipital horn and posterior body of the left lateral ventricle? What it could be?
Blood clots, or although it is not hyperintense in T1, I'd like to look, yes, in GRE. Yes, I can see now there is a hemosiderin ring around. In this diffusion,
so this is diffusion.
In this diffusion, there is a bright signal which consistent with the diffusion restriction, and that signal was not hyperintense in T1. So this is a abscess intraventricular with ependymitis, mostly due to complicated brain abscess. So this is an emergency.
Okay, fine. Next case.
Okay, I'm presented with multiple and multi-sequential MRI of an adult patient with no profile history. I'd like to take a general look by looking at this. I think this is T2 coronal. There is a diffusion, and I can see them in the sky here. In this T2, I can't see any right signal. I can't see any abnormal marrow signal here, and there is diffusion. Can I look at the sagittal?
Which sagittal you want?
Sagittal proton.
Sagittal T2?
Yes.
Yeah.
Yes.
Yes, you can scroll, yeah.
Yes. Now, yes, in this sagittal T2, I again confirm that there is suprapatellar effusion. I can see there is what's named the double BCL sign, where I can see the posterior horn of the lateral meniscus flipped into the intercondyle notch. I mean, parallel to the posterior cruciate ligament. This consists of double bucket handle tear. However, I will confirm this also by looking at the proton density fat sat for any marrow edema.
So you think it's a lateral meniscus bucket handle tear, right?
Yeah.
And what about the ACL?
And I want to comment also regarding the ACL. I can't see it is fiber here. Yes. The ACL would not be seen here.
So in how many cases with the bucket handle you see the ACL injury?
It is common association usually. So I can't see the fiber of the ACL. I would like to confirm this also by looking at the axial to see it is an attachment. Yes, yes. Yes, I can see only the flipped meniscus in the intercondyle notch and the effusion. The ACL
So this is the flipped meniscus, right?
Yes.
What is this?
This is the BCL. Yeah. So it is seen truncated here. In this sequence also, I can't see any marrow signal. This
Okay,
could be
so
chronic.
just by the one, just scroll this image for me and can you confirm your findings? Just for the note down that what is the final ACL injury and bucket handle tear of what?
This is in summary a traumatic knee injury with the chronic ACL tear and bucket handle tear. I mean posterior horn of lateral meniscus, of the medial meniscus. Medial meniscus.
So it was medial meniscus, right?
Yes,
yeah. Throughout the discussion, you were saying it's lateral.
Okay, sir.
Okay. Sorry. Yep.
Okay. This is a frontal chest radiograph.
Routine screening
of an adult patient who presented with routine screening, where what's striking abnormality, I can see there is right lower lung zone inhomogeneous opacity seen, causing a mediastinal shift and leftward diffusion of the heart border. The opacity seen silhouetting the right cardiac border. It has a superior bubbly-like or
Yeah.
Wavy border, and I think it has superior wavy border. There is superior opacity.
So what do you think this opacity is?
This is presented incidentally in patient with routine screening, and it is filling the here the differential diagnosis is wide because it is also filling the cardiophrenic angle. Could be this is a mediastinal lesion.
For instance, what?
Could be this Morgagni hernia or pericardial fat.
Okay, so how can you shortlist these things for me? Anything number 1, number 2, and number 3?
The fat is the density will be homogeneous, and less like that. This could be Morgagnian hernia, my first possibility.
So what you will do?
I would like to see characterize it further on cross-sectional CT imaging.
How will it benefit you?
Yes, it will aid in it is true localization, whether it is, as my assumption, is it mediastinal or
okay,
from
if it comes
abdomen.
out to be positive for the Morgagni hernia, then what will you do?
Given that it is incidental presentation, I think they will do, and this, the content of the hernia, I think what they will need only follow up because adult, no acute symptom.
Okay. Shortness of breath.
This is a scout image of CT of an adult who presented with shortness of breath, where I can see there is gross cardiomegaly involving multi-chamber. I can see there is splaying of the carina, and also there are bilateral symmetrical reticulonodal infiltrate involving both lung parenchyma. There is also dorsolumbar scoliosis. Given that patient presented with shortness of breath, I can't see any pericardial calcification or valvular. I'm thinking of possibility of, if this patient cardiac, possibility of rheumatic heart disease, could be mitral valve. So I will confirm my finding and
with mitral valve, what? Sorry?
Mitral valve disease.
Okay, okay, fine. So patient undergone the CT. Can you scroll it for me? Just take these images here. Can you scroll it?
Yes.
Yeah.
Yes.
Yeah.
So this is a contrast.
You comfortable with 5 mm thickness, or you want a less thickness? Then I can provide you, but I think so it's fine. Yeah.
Okay, it's fine. So this is a contrast enhanced CT of the chest of the adult presented with shortness of breath. You can see there is a hyperdensity lesion seen within. There is hyperdensity seen outlying the pericardium and the mediastinal structure, with the reflux of the contrast to the IVC. And it is seen compressing both pulmonary veins, the cardiac chamber here. The left atrium is not, the left atrium is not grossly dilated. So, Can I look at the lung window also?
So what on the mediastinal window you are thinking? I can show you the lung window, yeah? Just tell me your thoughts.
I'm really stuck here.
Okay, but what actually you are thinking? Like, it's fine to be stuck, but
I think there is spreading soft tissue attenuation, insinuating and encasing the mediastinal great vessels. And
okay, so let me give you the lung window then.
okay.
Yeah.
Okay. Lung window again also showing that seen in the scout where I can see interstitial reticular pattern, miliary type, I think. It is more on the right lung side. The left lung less affected. I can't see any sign of pulmonary embolism or this was not excluded in the contrast.
So what's your diagnosis then?
Given that this only presentation shortness of breath, if the patient has any other toxic symptom, I would like to, I'm thinking of possibility of infection.
Infection? What sort of infection appears like this?
Yes, this is soft tissue density engulfing the mesenteric vessel more with the neoplastics, would disseminate the metastasis, I think. So
Okay, thank you. So let's coming to the feedback then. Okay, so it's okay, it's fine attempt. So you are appearing this time as well, okay? Yeah, everyone is appearing who is giving the Viva today.
Difficult case.
So to make a mistakes over here is fine. To make a mistakes over there is not fine. So these are the practice sessions. Utilize them as much as you can for your benefit. Speak of your mind, okay? And try to be very restrictive in your terms and terminologies you are using. Don't be very wide apart. One time you are saying infection, one time you are saying neoplastic. Sometimes there is an overlap, like whenever there is a case of osteomyelitis, you have to say the osteosarcoma somehow, but still you have to 1, 2, and 3 your diagnosis. Like you have to prioritize something over the other due to certain reasons. And if you justify that reasons in your exam, then maybe you are right. If you justify that you are saying osteosarcoma due to this thing and osteomyelitis less due to this thing, and if it's justifiable, then nobody can argue with you. But if you can't justify the statement you have just given, then it is a lashback over you. Okay. So this case you did fine. History was given of the pelvic surgery regarding the ovarian carcinoma. So this is like a sclerosing peritonitis, if you see, right? So it was all in the mesentery. It's fine to say, yeah, it's good to pick up the calcified area over the hepatic region and otherwise. So you performed fine. Regarding this one, again, I very clearly said that the patient came for surveillance, right? So what you should ask for, you should compare it with the previous films.
Yes.
And if it's there, then you should note, like this here we lack, and this is our wrong practice, which UK and any other senior radiologist should deny and should imply in our practice that we should avoid the patient from radiation as much as we can. Yes. Right? Yes. When you don't have to treat the morgagni hernia, when patient is totally symptomless, you don't want to undergo an unuseful surgery for the patient. You don't need a CT scan for this. Although if there is no previous, so first thing you should ask for the previous films, if any. If it is continuous, if it's stable, and if the patient having no symptoms, then nothing to do. If patient comes with some acute symptoms, any other thing, then you can ask for the CT scan and other justifiable things. But in this case, it's not justifiable, okay? And this is very well clear. The some stomach bubble is over here, but this, I think so, these are the well demarcated colon or bowel loop. You can see the air in it. So
Yes.
to give the other differentials in this case, like the pericardial fat, and this is not right thing, which you deny yourself after poking you. Okay? So you have to avoid these things. Like examiners should poke you less as much as possible. You should prioritize your things, your own self. He should not asking you that why are you saying this, why are you saying this, why this not, why that not. You should yourself tell that I am not thinking of the pericardial fat due to this, and the hernia would be on the top of the list. Okay.
Okay.
This again, you did, you continuously saying lateral meniscus, although I multiple times focused and enforced,
Yes.
okay, buckling, handle tear of the lateral meniscus, you said. Then I tell you again this and show you this. Here it's on the coronal view, a very beautiful fluid
Yes,
cap
yes.
on the coronal images, right? So it's the radial tear of the posterior horn of medial meniscus, which is flipped into the intercondylar notch. Most likely ACL is partially torn, but it's not completely torn. But that's not a point of question of asking, because like I think and see a few of the fibers over here, although it's
Yes.
not completely traceable. I agree with that. But the thing to show is the bucket handle tear of the medial meniscus. Okay, so this one is the difficult case, which like I must say that it's really difficult. This was shown to me by the one of the radiologists in Radicon course, and I was told that few of the FRCR consultants do have that. And so this is a ventriculitis with intraventricular abscesses, and this is another abscess in the frontoparietal lobe. So this is a very beautiful case, and you can easily identify it when you see the post-contrast images.
Yes.
But until and unless you don't have a post-contrast images, you can't identify it so easily. But you should think over that lines. The whole of the left ventricle is dilated. There is a heterogeneous abnormal MR signals area within the occipital horn, but this is not within the ventricle. That should prompt you that this is something else going on. If choroid plexus papilloma or some carcinoma is over there, then it should be only the one only within the ventricles.
Yes.
There should not be something else going on within the brain other than edema and mass effects like things. So this is really something abnormal, which is extraventricular. So that should prompt you that no, it's something else going on. When this shown, very beautiful T1 hyperintensity shown over the ventricular lining, which also again then prompt you, no, it's not a neoplasm, it is something else going on. Here again, it has a very well defined T1 hyperintense wall. So these are the abscesses, okay? So this is
there a previous intervention also?
sorry?
Patient has intervention?
Maybe because this is an air focus.
Yes.
This is low on all of the sequences in the non-dependent part. So maybe
Yes.
patient has undergone. Ventriculitis should be there is some reason patient may be having a VP shunting due to the previous hydrocephalus, which leads to all these things. So it's fine to ask for all the intervention history in this, but this is the diagnosis. Okay.
Yes. Yes.
Then I showed you this. This you. I don't like it to say it an infection. I haven't ever seen infection insinuating. At last you use the word insinuating, infiltrative, and I like that. At least I said that, oh, you are on the right track. But then again, in the end, you said infection, and I said, oof, what should I say? So, okay, so this was a biggest blunder. When you are not knowing it, then just okay, then I am thinking of this, but not of infection, at least to such a beautiful case to say infection. I must say it's proven lymphoma.
Yes.
Okay, so infiltrative, insinuating hypodensities within the mediastinum. See how it's scalping over the pericard of the cardial chambers, over the pulmonary vessels and everything. So, and more the right lung is involved, because if you observe that this soft tissue is more so extending over the right main bronchus, more so as compared to the left bronchus. Left bronchus is okay. This is fine. But the right bronchus, the soft tissue density is extending over its course, more so superiorly as well as inferiorly. And that's why the right lung endobronchial spread maybe or some nodules over there. I must say that it's not actually miliary, it's more so central lobular type distribution, but it's fine to say whatever you think. And more so ground glass over the lower lobes. Left lung is almost completely spared. So it's a lymphoma. Okay.
Okay.
That's all I have shown you, yeah?
I think yes.
So 1, 2, 3, 4, 5. Okay.
Okay.
Thank you.
Thank you.
Thank you, Dr. Awad. Dr. Kamal, next candidate is Dr. Arushi.
Okay, Dr. Arushi.
Hello, good evening, sir.
Good evening. So from where are you actually?
I'm from India.
And your center is India or UK?
No, my center is in UK, but I'm from India. I've just cleared my PG a year and a half back.
Okay, okay. So let's start with you. Yeah, can you see?
Yes.
Okay.
Patient
presented in A&E with pain and vague symptoms.
So this is a frontal radiograph of the abdomen. Multiple dilated bowel loops are seen in the abdomen. The largest bowel loop shows a few haustra within, making me suspect a large bowel pathology. However, the other bowel loops in the left quadrant as well as the pelvis are also dilated. Since the patient is presented in A&E, I would suspect that this is a case of sigmoid volvulus with proximal bowel obstruction. For such cases, they can be managed conservatively. We would put a tube into the anus and hope for conservation.
Okay, okay. So are you sure that it's a sigmoid volvulus? I am as a consultant from the ER is asking you. Should we pass the rectal tube? Any other thought you want to say?
There is a small there's no obvious perforation. So we could take this patient up for a cross-sectional imaging to confirm these findings before passing the rectal tube.
So what else you are thinking in this case?
There is another possibility of cecal volvulus. However, cecal volvulus presents with small bowel proximal small bowel obstruction and not large bowel obstruction. Another possibility.
You said that this loop has haustra, right?
Yes.
A sigmoid has haustra?
No, sigmoid does not have haustra. I'm so sorry.
And what's the more orientation of this loop?
It's a more horizontal orientation, which is usually seen with cecal volvulus.
Okay, so you already correct yourself now.
Okay.
We will discuss it later on. Okay. Yeah.
This is a frontal radiograph of the right upper limb. There is gross aneurysmal dilatation of the right humerus in its entirety, with no obvious cortical break and multiple lucencies within. There's no soft tissue component, there's no obvious periosteal reaction. I'm assessing the other bones to look for similar abnormalities. However, I do not see a similar focus elsewhere. Could I request the age of the patient?
Young patient, like 20, 22.
So in a 22-year-old, I would like to consider the possibility of a fibrous dysplasia. I would like to rule out similar involvement in other parts of the body, to rule out a possible polyostotic fibrous dysplasia, which is
The
associated.
rest of the skeletal survey is negative.
So I would like to put forward a differential of monostotic fibrous dysplasia.
Mhm.
I would like to, I think this should be a chronic problem. So I would like to assess with previous images. If the patient has no acute symptoms, then this could be followed up.
Okay. And can you please tell me any syndromes associated with this thing?
We have McCune-Albright syndrome associated with it, which is precocious puberty along with polyostotic fibrous dysplasia. We could have Mazabrod syndrome, which has multiple soft tissue myxomas. And cherubism, which involves the mandible.
So with monostotic, the syndromes are less, right?
Yes.
Okay. So can you see the other case?
Yes.
Yeah, please ask the control.
Sorry, I'm just trying.
If I can scroll for you. Okay, it's come. Yeah. So increased inflammatory markers.
Okay.
Sorry.
Sorry.
That's okay. You can scroll from here or scroll the mouse between button. Yeah. Yeah.
Thank you so much, sir.
You're welcome.
I've been provided with axial images through the abdomen. This, I'm just assessing the images cranial to caudal.
Yeah, sure.
There's some hyperdensity which is seen within the gallbladder with no obvious GV fat stranding. There is a hypodensity seen within the left kidney with no fat stranding, presumably a cyst. There's a lot of fat stranding seen within the retroperitoneum. I will just go back to that and assess it. There's a there is a divertification of the rectus muscle anteriorly, which is
That's okay. Ignore that.
relevance. The soft tissue thickening with fat stranding around it in the retroperitoneal region. I'm just trying to assess that better. It appears to surround the vessels. So I'm suspecting a retroperitoneal pathology in this patient.
Can you point out from where and where it is extending?
Yes. I was just assessing the psoas to look for any obvious extension, but there is mild asymmetry on the psoas, which has me a little suspicious. I was also trying to see if there's any obvious ureteric dilatation, but I could not trace any. I think the pathology starts at this level, anterior to L5S1, and it's centered in this region. In such a case, I would like to assess the bony window to see if there's any underlying bone pathology.
What bone pathology are you thinking at?
It could be an infective lesion within the bone, which is extending out.
What infected lesion is called as?
Something like tubercular spondylodiscitis with a prevertebral
Okay.
axis.
Okay, sorry, I don't have the bone window, so we did the MRI.
So I'm looking at sagittal T2 weighted images of the lumbar spine. The soft tissue thickening previously seen on CT is confirmed on MRI. I'm trying to assess the bone, the vertebral column better. There's areas of T2 hyperintensity seen within the L5S1 with no,
Sorry.
which is centered over the antero-superior aspect of S1 and antero-inferior aspect of L5. There's no, there's subtle involvement of the disc with an anterior soft tissue mass. So in this case, there's no obvious extension into the posterior spinal.
So diagnosis?
My diagnosis would be a tubercular spondylodiscitis in this case. I would suspect TB over a bacterial infection because of the relative sparing of the disc spaces, as well as the excessive soft tissue mass anteriorly. So I would like to do a chest X-ray for this patient to rule out a possible pulmonary infection, pulmonary involvement. I would
Why you are not thinking the other spondylodiscitis causes other than tuberculosis?
Because bacterial spondylodiscitis, which is a possible differential in this case, tends to involve the disc more and has more destruction of the disc space.
Okay.
So I would like to drain this and then send that for culture.
So you drain it?
Yes, we should drain this abscess.
Okay.
Cavity in cases of TB. So it will be an image guided drainage.
Okay. So can you see the next case?
Yes.
Okay.
I've been provided with axial T2 images of the brain. I'm sorry, the images are just skipping. Yeah. So I'm just going to scroll cranial to caudal to look for any obvious abnormality. There's a T2 hyperintensity seen centered over the left thalamus, which is probably a VR space, but I would like to correlate that on my other reformatted images. There's an area of altered signal intensity. On this particular image, I'm slightly, I'm torn between whether this is centered within the cerebellum or the ventricle or the brainstem. It appears to be centered within the cerebellum or compressing the fourth ventricle. There is surrounding edema. There's heterogeneous signal with an area of almost signal void within the lesion, which could represent some degree of calcification or a vessel within. I would like to assess this on a T1 image, as well as diffusion restriction and post-contrast. Could I? Okay, thank you. This area appears extremely bright on T1 images, which makes me suspect that there is
Yeah, you keep speaking. Yeah.
There is some either soft calcification or hemorrhage, more likely hemorrhage. I'm looking at the diffusion images now. There is an area of DWI.
Quite artifact, sorry for that, but yeah.
There's an area of high signal on the diffusion, which most likely has low signals on ADC. So there's central diffusion restriction, which is more likely to be a bleed. I would like post-contrast images if they're available.
So the thing is too much hyperintense on T1. How will the contrast will help you in this case?
Could I have a subtracted contrast?
Sorry,
enhanced?
we don't do that.
Okay. So I'm not sure if there's any real enhancement in this lesion.
So
but
what do you think is the reason of bleed in this case?
So I'm suspecting, I'm sorry, could I request the age of this patient?
It's 25.
25. So in a 25-year-old with a T1 hyperintensity that is based within the cerebellum, I'm suspecting this to be a hemangioblastoma, which has bled internally. In such cases, there's a propensity for...
Okay, and what other things, something less benign, something less aggressive you can think, something benign?
Possibly could be a bleed, but I am not...
Bleed in what?
Bleed.
I agree with the bleed. Bleed in what?
It could be a... okay, I would like to assess the sinuses. It's a bleed within the cerebellar hemisphere. I think the peduncles, the cerebellar peduncle. So at such an unusual location of bleed, we should rule out a possible underlying CVST, cerebral venous sinus thrombosis, which has caused a probable venous infarct.
Yeah, it was negative. No DVT, no DST.
So I'm still torn between two differentials. One would be a bleed, but I cannot think of any possible cause of bleed in this patient.
Female patient. Yeah, these are just the images. Okay, sorry. If I can.
Okay.
Yeah, sorry. I it's just in a AVI format, so I will play it for you. Okay.
Thank you. This is a T1 sequence of a female pelvis. There's a huge mass within the pelvis, predominantly centered on the right side. However, it is seen to cross the midline to the left. It has areas of heterogeneous signal intensity within, extremely bright on T1. I would like to compare it with a T1 fat saturated image to better assess the contents of the lesion. On the fat sat sagittal images, all the T1 hyperintense signal has suppressed. So since this is a young patient, my first differential in this case would be a fat-containing lesion arising from the ovary. So my first differential in this case would be dermoid. This is likely to be a mature dermoid because of the multiple contents seen within. This needs to be referred to a gynae MDT as this needs to surgically come out because of the possible of torsion, as there are multiple areas.
Any signs of complication you see in this case, in this imaging at the moment?
Could I request a T2? I would like to assess the follicles in the ovary.
Okay, I think so. This is T2 now.
Okay, I'm sorry.
Yeah, that's fine.
Has the patient, if I could request for the history, has the patient presented acutely?
No, it's just with the abdominal pain. Sorry, I don't have T2.
If this patient is presented to us acutely with abdominal pain, I would be highly suspicious of a possible torsion of the ovary that this dermoid has caused.
So how you confirm the torsion?
I would have seen the reformatted images to look for a twisted pedicle sign. And other than that, if the patient has acute pain, I would correlate it clinically.
Okay.
Which would be
fine. So this is the next case for you.
So I've been given contrast enhanced images, through the thorax. I will just scroll cranial to caudal.
Look in the abdomen, okay?
The liver appears normal, pancreas, okay. Other solid organs appear okay. There is the bowel does not appear good. I will just go back to the area of abnormality after finishing a scroll through. So this is a female patient with an overdistended bladder. There is circumferential thickening with heterogeneous post-contrast enhancement of a small bowel loop with no obvious signs of obstruction at present. I'm suspecting that there's aneurysmal dilatation. In my routine clinical practice, I would like to reformat these images in a coronal view to better assess. But a first differential that comes to mind would be a possible lymphoma, which is causing this. I'm trying to assess.
Just 1 minute, yeah. Yeah, you keep speaking, yeah.
I'm trying to assess for any lymph nodes that I could find to help me come to a conclusive diagnosis.
So what's the possibility if you find the lymph node, and what's the possibility if you don't find the lymph nodes? So here it is, and I think so there are lymph nodes, yeah.
So I'm still suspecting a lymphoma because of the aneurysmal dilatation with no obvious proximal obstruction, because GI malignancies such as adenocarcinomas usually do not present with aneurysmal dilatation, and they would have a component of if the mass becomes this big, they usually tend to present with an obstruction rather than an aneurysmal dilatation. Then other possibilities GIST, but they're most likely eccentric lesions which have a more exophytic component, which was not, I'm extremely sorry, I don't know what happened, which was not very apparent in this case. So I would suggest.
So quickly, this is the last case for you, yeah?
So I've been provided with axial images of the brain. There's a hypodense area which is seen abutting the midline falx. On these images, it appears to be intraaxial with surrounding vasogenic hypodense edema. I would like to better assess this with a post-contrast image.
What are you thinking of?
I need to confirm if this lesion is intra or extra axial. If it is an extraaxial lesion, a possibility could be a Fox mechanism.
Can you tell on these images that it is intra or extra? You can scroll these, yeah.
So the lesion is hyperdense and it appears to be intraaxial in
You there? Hello?
Hello, Dr. Arushi, we have lost your voice.
Yeah, I'm sorry. I was just trying to scroll, but
okay. I think, yeah, I'm scrolling for you. Okay.
Thank you so much. There are foci of calcifications which are seen cranially. So I think my possibilities in this case would be probable intraparenchymal bleed, which has with surrounding vasogenic edema. Could I request a history for this patient? Has this patient presented acute
unconsciousness?
Unconsciousness. So if this patient is dehydrated, I would again have to put in a possibility of a cerebral venous sinus thrombosis, which has caused an hemorrhage in an abnormal location. If this lesion enhances brightly, then my differential would change.
So now what do you think?
There is a lot of post-contrast enhancement seen within the right frontal lobe. And there's early drainage within the venous sinuses as well. So after the post-contrast images, I'm suspecting that there is a huge right frontal atriovenous malformation.
You suspecting it or you're confirming it?
I'm confirming it because I can see the arterials
Okay.
and the early
Okay.
venous drainage as well as the meatus.
Fine. Yeah.
I would
So
recommend-
coming back to the feedback, yeah, it's fine. Yeah. So how you think you have performed? Yeah, it's fine. It's totally fine. And
I think
you,
I
all
messed
people
up
are
some
making.
basic things, intra and extraaxial and vesical volvulus, which I'm not very happy with.
Yeah, that's the only thing I'm trying to focus from the first candidate till now. And the only thing which we have to work on the daily basis. Like once we say it's intraaxial, over DDs are totally different as compared once we say it extraaxial, over differentials are totally different. Okay, so we have to always assist our findings with some sportive things. In this case, you saw yourself that it's a likely a large bowel loop due to hostrations. And although I must agree that there is few air noted in the rest of the large bowel, which don't come usually with the cecal volvulus, but still the orientation, the horizontal orientation, the look and the presence of hostra is very well specific for the cecal volvulus in this case as compared to the sigmoid volvulus, which should be coming from the pelvis towards the upward, which I here can see that it is looping all around here. Okay, so this was the cecal volvulus. And cecal volvulus is like an emergency. It's an emergency. You can't wait for it because once it's more than 9 centimeters, cecum has a very high chances of perforation. And then you have to intimate the primary physician immediately to deal for it. Okay. So this you did good. It was fibrous dysplasia. It was like a fine attempt. All things were mentioned, like the periosteal reaction, soft tissue fractures, and all negative points, pertinent negative points. So again, when you come on this, you can be asked from the Viva questions, which you have answered very well. Okay. So this one was also fine. This was straight away a dermoid. And no free fluid in it, no adjacent stranding, no significant peritoneal disease, and all other things are negative. So it's like a simple mature dermoid without any definite complications. In this, you have to refer to the gynae, and then more than 5 centimeter it should be removed. Or okay, so this one you picked it very well. And the good thing is you go in a very systematic way. You tell that there are stones, but no cholecystitis. You tell about the kidney cyst, but no adjacent stranding. And you were looking for the inflammatory things from the first hand, and you picked it very well in a good way. That here there is a soft tissue stranding and reactionary changes. But here I little bit disagree. Because I see in my view, I think so the main center of the disease is the disc. Okay. So the main center of the disease disc. Vertebrae end plates are not very bad. They are not very bad. There's just edema along the end plates. If you see the TB, the end plates are quite irregular, shaggy, destructive, eroded. But here the end plates are not very bad, but there is a main centered over the disc and predominantly to one side of the midline and not to the other side of the midline, right?
Yes.
So you see whole here, it's going inside the disc, but here the disc is okay. So it's the main epicenter is disc, no paravertebral, no posterior components, adjacent psoas, which you already mentioned in the history that like you are looking for, or I have not seen it, but there is. So it's fine to say the differentials of the tuberculous or the other one, but always like don't say it's tuberculous. You should say that it is spondylodiscitis, could be tuberculous or bacterial, like TB. You know, the UK people are a bit touchy about. Yeah.
Yes.
Okay, so this again, you picked it well and everything, hemorrhage and this. You asked for the post-contrast image. I asked what enhancement, and you tactfully said that I want to see the subtractive images, which you have know that I don't have. So that was a tactful answer. I like that. But all other things apart, I think so the look over the T2 sequence is quite specific popcorn appearance. And it is a cavernoma in a young patient. I ask you that tell me some less sinister benign etiology. So it's a cavernoma with the bleed most likely, but it's fine. Yeah, differential game and other things. I don't deny that, but okay. So here you picked it very well. That's a very good attempt that you picked up the aneurysmal dilatation and you said that it's a small bowel lymphoma most likely, and you tell why it's not the adenocarcinoma, so it's okay. So I think so there's are your cases. Dermoid,
One
FD,
more is left, sir, the
fecal.
AVM.
Yeah, the AVM one, although you have said, tell very right, but whenever you see this and these calcifications are the secondary sign of the AVM, because you can see usually that along the course of the vessel that there is abnormal area, and this is actually not the vasogenic edema, but this is actually the volume loss if you trace it over the ventricle.
Yes,
Right.
sir.
So this is actually the volume loss. Whenever there is a chronic AVM sitting over there, it is actually stealing the blood and there is a loss of white matter in the vicinity. So it's basically the volume loss. And this is basically the big nidus over there. So if you go very nicely in this case, you tell everything, then you can be asked about the feeder and the drainage and its classification. What is the eloquence and what are the dangerous points, what are the non-dangerous points. If you perform it very well, then the Viva questions like with that. Okay.
Yes. So I'm sorry, just one small
Yeah.
doubt. I'm continuously on a CT. Whenever we get presented with a midline lesion, I'm always confused about intra and extra axial. If you could just give us a few pointers on a basic.
Okay. Although there's always a doubt in the non-contrast studies specifically sometimes, but to be very frank, if it would be extraaxial, there should be some CSF cleft sign around it. I
Yes.
can see a thin linear cortex on its outer margin over here.
Yes.
Yeah, I think so, you people can appreciate that. So these sign and absence of the cleft is like well shown that it could be the intraaxial thing, which is stealing the blood from the all over the area.
Okay.
Yeah.
Thank you. Sir. Thank you.
So this is all over the cases. Okay.
Thank you.
So yeah, welcome. Yeah, you can please leave the mouse. Yep. So the last candidate now.
Yes, Dr. Kamal, I'm here.
So you are ready?
As much as I can be.
Okay. Okay, that's good. So let's start with this. You can see the screen.
Yes, I can see the screen.
Yeah, just let me enlarge it for you a bit. Yeah. Okay.
Okay, so I've been provided with a scout image of a CT chest and abdomen. In this scout image, I can see that there is a visible right-sided superior mediastinal widening, which seems to, within the constraints of the scout, I feel that it is going above the clavicle. I can see the right hard border. The left paratracheal area seems unremarkable. Considering that I can see the hyla, I can see the right hard border, I feel that this lesion in the right side of the mediastinum going above the clavicle can either be in the posterior mediastinum or within the lung. So I would proceed further with a contrast enhanced CT for further evaluation in this patient.
And what if I say it's not within the mediastinum? Any other possibility can you point out?
It can be in the posterior aspect of the lung, which is above the clavicle, or if I cannot trace this soft tissue mass. If it is merging with the soft tissues of the neck, then it could be even enlarged thyroid with retrosternal extension. That is another possibility apart from the lung lesion.
Okay, so you can ask the control from me.
Yes, okay. I have asked you? Okay.
Yeah.
Okay, so I have been provided with the contrast enhanced axial CT, neck and chest. I'm going to first scroll craniocaudally just to have a quick look till the last slice of this
Yeah,
imaging.
it's fine. Yeah.
Okay.
Just go up.
Okay, so the epicenter of the abnormality, which I'm seeing in this portovenous image is, sorry, in the, sorry, it is,
Yeah, it's okay.
okay. So it is centered around the right side of the neck in the right parapharyngeal space. I can see a necrotic, peripherally enhancing lesion, which is pushing the trachea and the esophagus to the left. It has a mass effect. It is extending up to the midline, and it is crossing all the way down to the retrosternal extension, up to the vascular or the arch of aorta. Now I'm trying to ascertain that this enhancing necrotic collection, its origin, I'm trying to trace if there is, it is nodal, I believe, that there is a sort of, either it is nodal or it's a parapharyngeal abscess, which has extended all the way down. This is an emergency. I would immediately convey the findings to the referring clinician because it is causing significant shift on the trachea. And I would involve the interventional radiologist to drain this collection for the cytology and culture.
Patient has this swelling from long years and it's suddenly enlarged.
Sorry, it's chronic and it has now
Suddenly enlarged, yeah.
Okay, suddenly enlarged. So this, the other possibility, actually in this region, there could be.
Can you focus the thyroid for me?
Thyroid, yes. Actually, I've been trying to find the thyroid. This is the left lobe of the thyroid gland. This one, this hyperdense area. And I cannot see clearly the right lobe of the thyroid gland. So the history, which is now available to me, that this is something which has been present for long and now has presented, makes me think that this is an enlarged right lobe of thyroid gland. And the fact that he has presented now means that there has been some superimposed acute complication of it. With this necrosis, I still believe maybe this patient has some sort of abscess within the thyroid gland, which is a bit odd, but still a possibility. Malignant transformation, I would keep low because then the patient would not present acutely. It would be a slow growing process. But with the acute history, I'm thinking that this is therefore, because I cannot see the right lobe of the thyroid gland, so it is an abscess of collection in the enlarged thyroid gland and an inflammatory process going on. And again,
okay, so done?
Yes.
Conclude?
Yes.
Okay. Yep.
Okay, so this is frontal radiograph of a pediatric patient. I can see that there is a portacath inserted on the left side, and step is in the region of the right SVC, in the region of SVC. I'm looking at the cardiac size, which appears to be within normal limits for this child. I'm looking at the both lung fields. There is a subtle tram track appearance of the perihilar bronchi on the left side. There are subtle dilated bronchi involving the right upper lobe as well as the left lung upper zone as well. The bases are relatively spared. The skeleton and the humeral head on the left side is fine. The right humeral head seems to be a bit superimposed. I'm not sure about whether it's proper positioning or not, but it seems to be a bit
focus
sclerosed.
on the bones more.
So the right humeral head seems to be a bit dense and sclerosed as compared
Any
to
other
the left
reason
side.
of other being more loosened as compared to this being dense?
So the other possibility could be that the abnormality is on the left side with lucency, but it's quite well demarcated with a quite clear zone of transition actually in the left humeral head. I feel that the splenic flexure is also under the left hemidiaphragm, so I'm wondering if there's this is a case of atrophic spleen or autosplenectomy. The humeral, the vertebral bodies within the constraints, I see it's unremarkable. I do not see any H-shaped vertebral bodies. I do not see any cholecystectomy clips. The thought process which is going in my mind right now, because I saw that this is a porta cat, which means the patient is chronically ill and is being treated for some long-term disease process. So initially I was thinking with these dilated bronchi, whether this patient has cystic fibrosis.
No active lung complaints here.
Okay. And plus the fact that there seems to be some sort of pathology on the left side. Okay, sorry, there is no scapula on the left.
Thank God. At last you pick it. Yeah. So now
this patient has had removal of the scapula in a child. This is most likely neoplastic Ewing sarcoma of the scapula, and that's why there's a
the case
cat.
closed. Okay.
Yes, the case is closed.
Okay.
Okay, so this is a frontal radiograph of an adult patient. The first abnormality which I can see is that I can see a loosened tubular loops within the left hemithorax with air fluid levels. I really cannot make out clearly the left hemidiaphragm, which I feel is disrupted. There are atelectatic changes in the visualized lung, left lung. There is mild deviation of the trachea and the bronchi towards the right. There are medial sternotomy sutures. I'm quickly looking at the visualized ribs to see if there is any traumatic rib fractures. I do not see any trauma. So I believe this is a case of neglected diaphragmatic hernia on the left side with herniation of the large bowel into the left hemithorax. I would inquire the clinician if the patient has presented with acute symptoms, especially with the air fluid levels. And if yes, then immediate referral to the surgery. And with discussion with them, I can proceed further if they need with contrast enhanced CT abdomen. Otherwise, I'll tell them that there is diaphragmatic hernia with herniation of bowel loops.
Okay. Young patient with acute unconsciousness here.
Okay. So a young patient with acute history of unconsciousness, I've been provided with axial T2 images of the brain. I'm scrolling first craniocaudally. Okay, so in the first look of this, these T2 axial images, I can see that there is abnormal T2 signal intensity involving the right temporal lobe, which is extending all the way up to the parietal region, along with involvement of the basal ganglia, the caudate, up till the level of almost the right frontal lobe. So it's a diffuse process. Abnormality involving the right cerebral hemisphere and the basal ganglia. I would like to look, I do not see any midline shift. I do not see any hydrocephalus in the present CT. I would like to see the T1 images.
Yeah.
So in the T1 images, the lesions which I saw on T2 is hypointense. I would like to see the contrast enhanced images and diffusion if possible. So now I've been provided with the contrast enhanced images, and I don't see any significant enhancement of the lesion, the abnormal signal intensity lesion I saw per se. Do I have the diffusion images?
Yeah.
So on the diffusion images, I have the abnormality demonstrates increased signal intensity. I would correspond it with the ADC, and if it is low, yes, so it is low. So this is restricted diffusion. So considering the extent of the abnormality and the restricted diffusion and no enhancement on the post-contrast images, I would consider the a large MCA infarct in this region as my prime possibility. That would remain my first differential.
Any other differential?
Yes, a multicentric, a glioblastoma multiforme would be less likely because there is no enhancement. Encephalitis, again, I'm keeping it low in differential because I don't see any enhancement, although I cannot rule it out completely. So these are my differentials at the moment.
So clinicians are very worried that you are quite confuse them now what they should do with the patient. Should they treat infarct? Should they start antibiotics for the encephalitis, or should they investigate it further for the tumor?
I would tell them this is infarct.
Okay. So any reason you can tell them that it's short infarct in this case? It's quite evident or not in this slice, yeah?
Okay, in this slice, actually, okay, sorry. Because it's MCA territory largely, that is why. Yeah, I know that, you know, the fact that the basal ganglia is also involved, I would, because it's territorial, that's why I'll tell them this is MCA.
Okay, fine. Just give me a minute, yeah?
Sure, sure.
Okay. Yep.
Okay, so these are axial T2 images of the brain. I'm going caudocranially first to have a look. Okay. So in the first go, I can see that there is abnormal T2 signal intensity, again involving the right cerebral hemisphere. In the right frontal lobe, I see additional subtle abnormal signal intensity area. Again in the right parietal area, because when I compare it to the left, this seems abnormal. I'm going further cranially down, again an abnormal. So there are multiple abnormal signal T2 signal intensity, which I believe is largely involving the cortex on the right side, and perhaps a few of the subcortical U fibers of the white matter as well. I would like to look at in my routine practice, I would look at FLAIR and T1.
So just a quick look, this is FLAIR.
Yes, so the FLAIR actually redemonstrates it better, and there are multiple abnormal signal intensity scattered in both the cerebral hemispheres, which are low signal intensity on T1. I cannot see any high signal intensity. Can I, at the diffusion weighted, I can see that there are multiple areas of increased intensity, which are not low on ADC. So these are not restricted. These areas are not restricting.
Yeah. So what are you thinking of?
So I'm thinking that this is not infarction. These are scattered areas in both cerebral hemispheres. I have been provided with sagittal, and I feel that few of these lesions are also parallel to the ventricles, and many I saw in the subcortical U fibers. I'm guessing that this is an adult patient.
52 years.
52 years. So this could be, although it is not predominantly involving the callososeptal interface, but I would still keep multiple sclerosis, because it's involving the subcortical U fibers. I will keep multiple sclerosis as my number one differential. I would ask
what else?
for what else. It could be, I'm thinking that if these are cortical tubers in a patient who has been remained undiagnosed for a long time, I also see abnormal signal intensity actually in the infratentorial aspects as well. I didn't look at the contrast enhanced. Another thing which can happen is that these are multicentric, supra and infratentorial. It could be metastatic lesions as well from an unknown primary. So a contrast enhanced sequence would help. So I've been provided with contrast enhanced sequences, and I'm going, So I'm seeing multiple ring enhancing lesions in the brain in supra and infratentorial regions. So a DD of ring enhancing lesion which is not restricting on diffusion, I would keep metastatic lesions as the prime possibility. This is a male patient. The focus can come from the lung, it can come from the renal, it can come from the thyroid. So I would, if the patient has not been investigated already, I would ask for a pan-CT from the clinician to look for the primary to find the source of these metastatic lesions.
Okay. So last case, should I?
Yes, go ahead. Come on.
I had one abdomen case. I don't know where it's gone. Yeah. Okay, it's fine. I think I missed that. Yes, I couldn't find it.
I can see an abdomen though. It's not that one.
Yeah, this is has
Different.
already been done.
Okay,
Yeah,
okay, okay.
this
okay,
has been
thank you.
done.
Okay, Dr. Kamal, thank you.
Yeah. Yeah, just give me a minute. I give you the feedback. Yeah.
Yes, Dr. Kamal.
Okay, so coming to the feedback then.
Yes, Dr. Kamal.
So it's like, so how it's like how you perform. So you know already your basic points which you have missed. Although the fluency, the way of talking was very good, but sometimes like you are missing up the main thing which you should set in the exam, right?
Right.
So here it's very obvious that it's the gyral swelling, and there is like interface of the gray matter seen in between the basal ganglia involvement. So it's like a very typical appearance of the infarct, and I don't think so that we should involve, after seeing that much diffusion restriction and everything, we should involve the neoplastic etiology in this case, right?
Right, right.
And the second thing I want to emphasize, like if you see, this is the flow void of the internal carotid. I can't see it over here.
Yes.
It's absent.
Yes.
It's not
yes.
over here, right? So
Right.
it is the completely blocked internal carotid artery in a young patient, which is a very dire emergency, and you have to convey it immediately because the patient is just 36 years old. Okay.
Yes.
So that was like, I was when asking that in this image, can you confirm anything? So I was like pointing out towards the ICA.
Yeah.
So that should be pointed out.
Yes.
These things, although adult patient metastasis could be the interdifferential, but what I want to enforce, there was a very good catching point, which I try to although stabilize the image over there. If you see this low focus, low focus on the background of these edema signals, as well as in the posterior fossa, you see these low signals, this low signal, which is not high on T1. So this is most likely calcifications or calcified areas. So these are all tuberculomas. Okay, so ring enhancing lesions, metastasis should be in the DD, no doubt. But now it's the time to say the TB. You should
Yes.
raise the alarm. Like
Yes.
after seeing these low T2 signals on the background, these are very highly specific for this. So you should speak up that it's the TB most likely. The number one thing, then comes the other things off. Okay.
Yes.
Then I showed you that scapula you picked up. Yeah.
Yeah.
So this was the case which was also shown to me in the Radicon course in the Dubai, which I attended a long ago. But this was shown to me.
Yeah.
So they have such, because they were all FRCR examiners. So I doubt they have these cases. Okay. So you can see a metallic thing over here, and there's totally absent scapula, which we know, we all radiologists in practice, we know we always miss it. But after seeing this PAMA cath, and you were totally trying to point out that there is some sinister thing which he or she is getting up some the medication and everything. And when the examiner is saying, okay, focus more on the bones, then you have to pick it up. I should not be that much poking at the instance I have taken it to. You should pick it up a little bit earlier. This thing you have explained well, like it's a hernia and everything. But can you explain me why these are two air fluid levels just parallel to each other?
This is colon, I believe.
And where's the stomach then? This is the stomach?
It's everything is intersposed.
Yeah, that's fine. That's fine. Yeah, it's
Yeah.
like difficult thing to tell, but you pointed out towards the city and everything. So this was the stomach, which has flipped over with two air fluid levels, and this is on the background is the colon. So this is mesentero-axial volvulus, and this thing. I was shown one volvulus on my exam in FRCR, and the examiner was like, I was not picking it up in the first instance. There was pulmonary embolism, and he was saying that what else? And there was an volvulus in the mediastinum over there, and he was like continuously poking me that what is this? Okay, so next I showed you. Okay, yeah, this one I think like a little bit more. It's a very clear cut within the colon, within the thyroid, because this is the left lobe.
Yes.
I can't see at all the right lobe.
Yeah.
And this is all going on. What I can say, the most, although like maybe my reason is not that much like but if retropharyngeal abscess it will be, and whatever the abscess it would be, the fat planes would not be very much neat with the vessels and everything, right? You can very well demarcate this thing and going down in the along the, whenever you see the retrosternal thyroid extension, you always see in this track.
Yes.
Yeah, in the tracheoesophageal groove, it's going on. So it's a clear thyroid lesion. So to say it an abscess is like bit blunder. If you see it over here, the airway is totally shifted towards the left side.
Yes.
Yeah. So this is also the point. If it's an abscess, it's in the AP view, it's totally masked. You should not see the airway like this, because the abscess will be, if I can explain you a bit further, you all, abscess would be over here. It pushed the airway anteriorly, right? Not mostly towards the on the one side, and not severely compressed it on the one side usually. It usually is towards the both side of the midline in the dependent space, and do not go that much anteriorly. So it could not be an abscess in my point of view. It's a very clear-cut lesion. Secondly, the biggest blunder in this case is not to asking for the lung window even, and there were the Mets over there.
Yes.
So this was the thyroid carcinoma with metastasis was my case in the FRCR Viva. So you can see here.
There is. Yes.
So there are multiple, actually, like 2 or 3 in this case, which are doubtful.
Yes.
So after considering all this, this is the lung carcinoma, then, thyroid carcinoma with metastasis. And if go further, then the examiner asks you that which type of the thyroid carcinoma is usually presents with the metastasis. So he asked me the names. I said the papillary, I said the follicular, but he said what is the most sinister type. It's the anaplastic maybe, but I couldn't recall at that time, but it is anaplastic. So it's usually rare, but it do exist. Okay.
Yes.
So this was the case, which I think so is a big mess.
Yes.
Okay. So these are the cases. I think so.
Okay. Yes, Dr. Kamal. Just one question. There was, you remember the case you showed to Dr. Ijaz in the beginning, the first candidate with the eye changes? That was Thyroid bulbi, the left eye.
Yeah. I remember.
It was Thyroid bulbi, right?
It was for it was for Thyroid bulbi. That was a totally incidental finding.
Yes.
I think so. This one is the case. No, sorry. It was for Thyroid bulbi, and the other thing was totally separate from that.
Yes, exactly.
So,
no, I remember that. Just wanted to confirm because it looked like
that was for Thyroid bulbi. That was for Thyroid bulbi, and that has no link with the rest of the pathology going on within the brain.
Understood, Dr. Kamal.
So these are the old cases. I'm sorry for being a bit difficult. I don't know whether these are a bit difficult or not, but these are the real cases which usually come in the exam. These are all my personal, it's not from the Radiopedia or something. So I'm sorry for that. If you people find it a bit, some image degradation images or resolution images. X-rays were also from the routine practice. So 1 or 2 X-rays are from the Radiopedia, like this one is from the Radiopedia. If you find out and you say, Dr. Ahmed boasted that